Good afternoon. I'd like to first thank you and thank the Foundation for the privilege of speaking today, and also a quick thank you to the other physicians that you've heard from today that serve as part of the multidisciplinary team with whom it's really my pleasure to work. So Dr. Jealous sort of set the stage and gave you a lot of information about cardiac involvement of sarcoid, and I'm just going to pick up from there. I'm going to try not to repeat too much of what she went over, and really focus on the electrical or heart rhythm manifestations that we can sometimes see in cardiac sarcoid. So, as a quick outline, we'll review the cardiac conduction system just as sort of a lay of the land, so hopefully we can understand what the ramifications can be. We'll talk about heart rhythm disturbances that can come from cardiac sarcoid. We'll talk a little bit about the incidence, the types of sites of sarcoid involvement, and how that impacts what we see in the electrical manifestations. And then finally, the types of disturbances. We'll talk a bit about the treatments, although a lot of that has been gone over. So we'll focus again on the electrical system and how we manage those manifestations, and talk just briefly about the screening. So just to start, we'll talk quickly about the conduction system of the heart. So the way that the heart rhythm works is the heart has a natural pacemaker, if you will, which is the sinus node. And that fires 60 beats a minute, 100 beats a minute, whatever the body needs. And then that signal spreads across the top chambers, which are the atria, and then makes its way into the AV node. From the AV node, it spreads through these conduction fibers in red and blue called the bundles, the right and left bundle, down to the ventricles. And the ventricles are the main pumping chambers of the heart. So when you feel your pulse, when we talk about your heart rate, we're really talking about the rate of the ventricles. They're doing all the work of moving the blood around the body. You know, if the atria, the top chambers, were not really doing their work at all, if they were just kind of standing still, you'd still be able to walk around and do your thing as long as those ventricles, those bottom chambers, are pumping and moving the blood. But again, it starts in the sinus node, moves through the AV node and the bundles down to the ventricles that do most of the work of moving the blood around the body. I'm not sure you'll be able to see this. Sorry, this looks a little bit washed out, but this is an EKG. This is what we look at when we see the electrical, when we're kind of analyzing the electrical system of a heart. And again, I'll apologize, it doesn't show as cleanly as I'd like, but you can see at the beginning of each of these spikes, the spikes are the bottom chambers firing. Just before it, there's usually a little bump from the top chambers, and then there's a reset out here, this little bump here, and that repeats across the page with top, bottom, reset, top, bottom, reset. So that's a normal ECG, and we look at the intervals. We look at the time that it takes to go from the top to the bottom chambers. We look at the time that it takes for the electrical signal to spread across the bottom chambers, and then the reset time. So all of that's important information that we're gathering from the ECG. And when everything's working well, what we get is this, a nice coordination of the top and the bottom chambers, where the top chambers squeeze, and then the bottom chambers get the signal and squeeze afterwards. So you get this nice coordination with the top and bottom chambers, and again you can see these little bumps out front, in front of each of the larger spikes, so the top chambers firing before the bottom chambers. So now we'll move on to cardiac sarcoid and how that affects things, and we'll talk a little bit about the incidence. Dr. Jealous went through the numbers, and really some older autopsy studies have shown that that sarcoid can involve the heart in as many as 25 or 30% of the population. If you look at strictly Japanese population, that could be even higher, maybe up to about 58%. But it's not clinically manifest, meaning that we don't see electrical or heart failure symptoms in most of the patients where we can find that cardiac sarcoid. In fact, clinically manifest sarcoid is only about 5%. And if we look at the typical pattern of sarcoid, it sort of explains some of what we see from the electrical system. Again, this image, well, hopefully you can see it a little bit better. So you'll see the gray areas are patterns where sarcoid can affect the heart. And this is just a real sort of basic slide that can affect the heart in many different ways. But I'd like you to just sort of focus on the fact that almost all of these pictures showing the cardiac sarcoid, it involves that septum, which is the wall between the bottom chambers, the right and the left ventricle has this muscular septum, and cardiac sarcoid, for whatever reason, will often affect that septum, that wall, and it often affects the base of the heart, which is the area between the top and bottom chambers. And that's notable for us as electrophysiologists because that's where the electrical conduction fibers of the heart live. And so if you have inflammation there, you can have injury to those electrical conduction fibers. So how does sarcoid affect the heart? Well, as we talked about, in many people where we can see imaging studies that show some involvement of the heart, well, it may not cause any problems at all. It can be silent. But it can cause congestive heart failure, it can cause conduction abnormalities and arrhythmias, including potentially lethal arrhythmias that are lumped into a category that we call sudden death. Yeah, these show up pretty washed out, sorry. So in this one, you'll take my word for it that this is a patient that has what we call first-degree AV block. So they have some inflammation or injury to the conduction fibers of the heart, and there's a delay between the top and bottom chambers. So the electrical signal takes a little bit more time from the top to the bottom chambers. Again, what we're looking at is inflammation that can affect the septum between those ventricles where these conduction fibers live. First-degree AV block can be seen in patients with sarcoid. We can also see involvement of the heart where the bundles live, and that can cause what we call bundle branch block, meaning that some of these electrical conduction fibers down in the ventricles are working, others are not, so the signal gets to one side of the heart first and then slowly spreads across the bottom chambers. And then, this was to show you the difference between bundle branch block, which is marked up here. It's sort of a wider signal, and then the more narrow signal here that we're seeing in somebody with a normal rhythm. As inflammation or problems progress, you can get dropped beats, so the electrical signal going inconsistently from the top to the bottom chambers. And finally, you can get complete heart block. And again, this may be a little bit difficult to see, but what I'm trying to point out here is that there's P waves or signals from the top chambers that march through this, and the spikes have no correlate to what's going on in the top chambers. So if you have heart block, meaning the top chambers are not communicating anymore with the bottom chambers, fortunately, the bottom chambers will usually have a backup rate, so the person isn't going to keel over, but they may not be able to get around and do their usual activities because their bottom chambers are going so slow at just this backup rate. So these are some conduction abnormalities that we can see in patients with cardiac sarcoid. One of the more feared issues with cardiac involvement of sarcoid is ventricular tachycardia and ventricular fibrillation. So if patients have areas of inflammation and scar, these unhealthy areas of the heart can set up the ventricles for a little short circuit. So the electrical activity can start spinning around that area of inflammation or scar, creating this infinite loop or short circuit that creates this disturbance in the ventricular arrhythmia where the bottom chambers will start going very rapidly, so fast, in fact, that the bottom chambers aren't effectively moving blood, and these can potentially be lethal. So this is a patient that's in normal rhythm with the spikes coming at nice even intervals, and then you can see that they go into this very rapid rhythm of ventricular tachycardia with the spikes coming at incredibly rapid rates, so fast that they're probably not effectively circulating blood. So in ventricular tachycardia, we can see the top chambers firing at a slower rate, the bottom chambers firing at a much faster rate. And in ventricular fibrillation, well, the bottom chambers are just kind of quivering. They're going so fast, so not really effectively moving blood at all. Patients that have these potentially lethal arrhythmias, if they do not have a protective device, or if it happens outside the hospital, survival is very poor. So if 100 patients were to have these ventricular arrhythmias, only about 5 would survive. So survival is about 5% for these potentially lethal arrhythmias outside of the hospital and without a defibrillator. So what is the likelihood of somebody, what's the incidence of somebody with sarcoid having these conduction problems? It's really hard to put a number on it. You know, if you take patients that have clinically manifest cardiac sarcoid, about 26 to 67, I understand that's a broad range, will have some left bundle branch block. Complete heart block can be seen anywhere from 12 to 61%. And ventricular arrhythmias can be seen in up to 23%. But that includes what we call PVCs, these extra beats from the bottom chambers, and other arrhythmias that are not life-threatening. So it's really difficult to get to put a firm number on how many patients are at real risk for these dangerous arrhythmias with cardiac sarcoid. The treatment includes what the other physicians have talked to you about, immunosuppression, but from an electrical standpoint, we look at pacemakers or implantable defibrillators. For patients that are having ventricular arrhythmias, we look at a class of drugs called antiarrhythmic medications, and sometimes we'll pursue a procedure called catheter ablation, where we seek to find these electrical short circuits and take that unhealthy tissue, make a tiny burn to create just scar, so it can't create that infinite loop anymore. So there are some studies that suggest that early initiation of steroids for patients with cardiac sarcoid can improve the ejection fraction and may improve the recurrence rate of ventricular arrhythmias and even recovery of conduction disease. I just wanted to give you a quick understanding of what it's like to place a pacemaker or defibrillator, hopefully just to kind of demystify it and make it something that's not quite so scary. Most patients with sarcoid won't need a pacemaker or defibrillator. For those that do, the procedure involves a small incision underneath the clavicle, usually on the left side. Through that incision, we place a needle into the vein that runs underneath the collarbone, and then through that vein, we thread a wire, we call it a lead, that goes down to the heart. So in this scene, we're placing the pacing lead through the vein and then down to the heart muscle. And at the end of that lead, there's a tiny little corkscrew that screws into the heart muscle wall so that lead can see the signal that's happening in that chamber, whether it's the ventricle or the atria in the top chamber. The rest of the other end of the lead is hooked up to the pacemaker or defibrillator that sits underneath the skin, underneath the collarbone. And that gives us a way to watch and see what's going on with the heart rhythm, and then potentially deliver a rescue shock if the patient goes into a dangerous heart rhythm. So that's the defibrillator. This is an EKG from a patient that has ventricular tachycardia, or ventricular fibrillation, and then this spike here is the electrical shock, if you will, and the patient is rescued back to normal rhythm. And this is what the device would see, with the electrical signal in the top chambers going a lot slower than the bottom chambers that are in ventricular tachycardia, a shock delivered here, and the patient rescued to normal rhythm. So who needs an ICD? There are guidelines from 2014 that help us here. Patients who have cardiac sarcoid and have had spontaneous, sustained ventricular arrhythmias, so arrhythmias that last usually longer than 30 seconds or so, who have had prior arrest, or if the patient has an ejection fraction or strength of the heart that's significantly weakened despite optimal therapy, well, it's pretty clear those patients will benefit from a defibrillator. Possible need for a defibrillator, people that we think may benefit, patients that have normal ejection fraction, haven't had ventricular tachycardia or other arrhythmias, but have conduction system disease that's enough to warrant a pacemaker. Well, the current guidelines suggest that those patients may benefit from a defibrillator rather than a pacemaker. Unexplained passing out can also be an indication, and then inducible arrhythmias on an EP study. So if we're worried about the patient and we take them to an EP study and try and stimulate the heart and are able to induce ventricular arrhythmias, well, those patients may benefit from a defibrillator. And then it's a little less clear for the patients that have a reduced ejection fraction that's still better than 35%, despite medical therapy, but no other conduction system disease. It's a little unclear whether they would benefit from a device like a defibrillator. Good news is, for patients that have a defibrillator, those that meet the indications and get a defibrillator, these do a great job at rescuing patients from these potentially dangerous arrhythmias, and better than 95% of the time, it will rescue the patient. To give an idea of how often they rescue the patient, in patients that are thought to be appropriate for ICDs and get an ICD, there's about a 10 to 15% yearly incidence of appropriate therapies, meaning the device rescues them. 10 to 15% per year. The role of an EP study, so this is a study where we pace the heart in certain ways to see if a patient is able to be placed into these dangerous arrhythmias. We can use this to risk stratify patients who have a lower ejection fraction in that sort of 35 to 49% range. It's still a little unclear the role of the EP study, but we do use it in some patients. Antiarrhythmic therapy we use for patients that have the ventricular arrhythmias, have an ICD, but are maybe getting shocks or therapies from their device. So we can add this antiarrhythmic therapy on to try and reduce the incidence of shocks. It's effective only about 50% of the time. And then we'll also consider an ablation, the procedure that we talked about briefly, to take unhealthy tissue and create scar, and that's effective about the same, about 50% of the time. But for patients where they're getting these unnecessary or dangerous arrhythmias frequently, a 50-50 chance of success can still be an appealing thing. Just a quick image of what's involved with catheter ablation. It involves placing these small, sort of spaghetti-sized catheters through needle pokes in the veins and the arteries, and we can place multiple to try and find where these arrhythmias lie. We use computer modeling software to make a computerized image of the heart and find unhealthy areas and then make burns. So screening, at least from an EP standpoint, we look for symptoms, a yearly follow-up, looking at symptoms and exam, and possibly a yearly ECG for these patients. So in conclusion, sarcoid can involve the heart. It can be silent. It can cause heart failure or conduction abnormalities or ventricular arrhythmias. Medical therapy can certainly improve the cardiac issues that we see. And cardiac sarcoid can be treated with implantable defibrillators, implantable devices, antiarrhythmic medications, and even catheter ablation. And treatment depends on the findings of the individual patient.